we're getting into a really core topic for anyone heading into medicine: general anesthetics.
Absolutely.
I mean, whether you end up in surgery, managing sedation, or even dealing with pain management, you really need to understand these drugs.
You really do. This is foundational stuff.
Mm-hmm.
We're aiming to give you a solid grasp of how we achieve, unconsciousness, pain relief, muscle relaxation safely for patients during some pretty major procedures.
Yeah, it's critical. So we're using the document General Anesthetics,
Yeah.
uses, classes, and mechanism as our roadmap today. Our goal, our mission, if you like, is to pull out the absolute essentials about these anesthetics, the different types, how they work, which is fascinating, and the key things to watch out for. And we're tailoring this specifically for you, thinking about what medical students really need to know.
Exactly. And we'll stick closely to the structure in that document so we cover all the bases.
Perfect. Okay, let's start with the practical side then. Where are these drugs actually used day to day in medicine?
Well, the most obvious one, of course, is surgical anesthesia. That's the big one.
Right.
And here, we're really aiming for a specific combo of effects. Unconsciousness, so the patient isn't aware.
Uh-huh.
Amnesia, so they don't remember it afterwards. Analgesia, obviously, pain relief. And muscle relaxation, which, the surgeons often need to actually do the operation.
So it's like creating this controlled state for surgery.
Precisely. It allows for these complex procedures to happen safely.
But it's not just for the big surgeries, is it? The document mentioned procedural sedation, too.
That's right. Think about things like colonoscopies or maybe getting an MRI if someone's claustrophobic or can't stay still.
Okay.
In those cases, you might not need that full-depth surgical anesthesia, but you need the patient comfortable, still, maybe a bit sleepy. General anesthetics can be used for that lighter sedation.
Makes sense.
And also, in the ICU, patients on ventilators, they often need sedation with these agents just to tolerate having that breathing tube in. It can be really uncomfortable.
Yeah, I can imagine. And what about RSI, rapid sequence intubation? Sounds urgent.
It is. RSI is it's a critical procedure, usually in emergencies. Maybe the patient's airway is at risk or they're struggling to breathe.
Right.
You need to get that breathing tube in fast and safely. So we use certain general anesthetics that work really quickly. Propofol and etomidate are common ones to induce unconsciousness very rapidly. Sometimes muscle relaxation too, making intubation smoother.
Speed is key there, it sounds like.
Absolutely. But safety and monitoring are just as crucial.
Okay, and the last use mentioned was pain management. That one surprised me a bit. I usually think opioids for pain.
You're not wrong. Opioids are definitely mainstays. But ketamine, which we'll talk more about, it's a dissociative anesthetic, has found this interesting off-label use for acute pain, especially when opioids aren't quite cutting it or maybe causing side effects.
Yeah.
And it's even being looked at for treatment-resistant depression.
Wow.
Yeah, it works completely differently from opioids, which is why it can be so useful sometimes. A good example of finding new uses for existing drugs.
Definitely. Okay, so those are the main applications. Let's switch gears to the what. How do we actually categorize these drugs? What are the main classes?
Yeah, the document lays it out quite clearly into 4 main groups. First up, you've got the inhaled agents. These are gases or volatile liquids that patients breathe in.
Like sevoflurane.
Exactly. Sevoflurane, brand name, often Severane, and isoflurane, which you might know as Forane. Those are key inhaled ones.
Okay.
Then you have the intravenous or IV induction agents. These go straight into the vein for a really fast effect. Propofol is probably the most famous one.
Just called propofol usually.
Right. And also thiapental, brand name Pentothal, though it's used a bit less now.
Got it. What's next?
Third group is the dissociative agents. Ketamine is the main player here. You'll see it as Ketalar or Ketamine.
Ketamine. Okay.
And finally, the imidazole derivatives. The key example there is etomidate or hypnomidate.
So 4 main buckets: inhaled, IV induction, dissociative, and imidazole.
That's it. Knowing these categories helps you start to predict how they might work and where they'd be used.
Great. And thanks for including those Indian brand names. That's really useful for many of our listeners. Let's dig into some specifics now, starting with those inhaled agents again. Sevoflurane, what makes it stand out?
The big thing with sevoflurane is how fast it works, both going to sleep and waking up.
Okay, why is that?
It's mainly because it has low solubility in blood. Basically, if a gas doesn't dissolve much in the blood, it gets to the brain faster from the lungs.
Oh, makes sense.
And leaves the body faster when you turn it off. This smooth on, smooth off makes it really popular, especially for kids. Pediatric anesthesia often prefers sevoflurane because it reduces anxiety, makes induction smoother.
Right. Less stressful for everyone involved.
Exactly.
What about isoflurane then? You mentioned it's also common.
Isoflurane's main advantage is often cost. It tends to be cheaper.
Ah, okay. Practical consideration.
Very practical.
Yeah.
But it has this quite pungent smell. It's not pleasant.
Uh-oh.
Yeah, and that smell can sometimes irritate the airway, maybe cause coughing or even laryngospasm when the patient is first breathing it in. So for just breathing the gas to go to sleep, sevoflurane is often preferred because it's sweeter.
So a trade-off there between cost and maybe a slightly rougher induction.
Pretty much.
Okay, let's move to the IV agents. Propofol seems like it's everywhere in anesthesia. What are the absolute key points?
It really is a workhorse. Super fast onset, people lose consciousness in seconds. That's its big plus for induction.
But there's always a but, isn't there?
There often is. With propofol, the big but is hypotension. It can really drop your blood pressure because it widens blood vessels.
Okay, that sounds significant.
It is. You have to monitor blood pressure constantly and be ready to give fluids, maybe even drugs, to bring the pressure back up, especially in patients who are already a bit unstable or have heart issues.
So fast action, but watch the BP closely. What about thiopental? You said it's older?
Yeah, thiopental is a barbiturate. It was the induction agent for a long, long time.
Right.
Its use has gone down a bit with newer drugs, like propofol, having arguably better side effect profiles.
Right.
But the critical thing to remember, absolute must know, is you cannot give it to patients with porphyria.
Porphyria, okay, why not?
Porphyria is a group of genetic disorders affecting heme production. Thiopental can trigger a really dangerous acute attack in these patients. So asking about porphyria is a vital part of the pre-op history.
Got it. Crucial piece of history taking. Now, ketamine, the dissociative one, the notes say it preserves airway reflexes. That sounds different.
It's a major difference and really important. Unlike a lot of other anesthetics that can knock out your breathing drive and your ability to cough or gag, ketamine often lets patients keep breathing on their own and maintain those protective airway reflexes. That's a big safety advantage in some situations.
How does it work to do that?
Its main mechanism is blocking NMDA receptors in the brain. This antagonism leads to that unique dissociative state. The patient seems kind of awake, but they're detached, not feeling pain.
Awake but detached. Interesting.
Yeah, it's sometimes described as a cataleptic state. This NMDA block is key to its pain relief, too. It's particularly useful in, say, trauma patients where you want to maintain blood pressure and breathing, or for certain procedures outside the OR.
Okay, so very distinct properties. Now, we've touched on mechanisms a bit, but let's really dive into how these drugs produce these effects, the mechanism of action.
Right. The document breaks it down nicely into 4 steps.
Yeah.
Step 1 is just getting the drug into the body, into the brain administration and absorption.
So inhaled versus 5.
Exactly. Inhaled agents go into the lungs, quickly get picked up by the blood, and cross that blood-brain barrier to act on the CNS.
Okay.
IV agents like propofol or ketamine are injected straight into the bloodstream so they get to the brain extremely fast. Route matters for onset speeds.
Right. Direct injection equals faster start. What's step 2?
Step 2 is where the drugs interact with key targets in the brain. A major target for many anesthetics is the GABA-A receptor.
GABA, the
Yeah.
brain's main calm down signal, right?
That's a great way to put it. It's the primary inhibitory neurotransmitter system. Drugs like propofol and the inhaled agents basically boost GABA's effect. They bind to the GABA-A receptor and make it easier for chloride ions, which are negatively charged, to flow into the neuron.
So making the inside of the nerve cell more negative?
Precisely. That's called hyperpolarization. It makes the neuron less likely to fire, dampening down brain activity. And that's what leads to the sedation, the unconsciousness, the amnesia we see clinically. They enhance the brain's on-off switch.
Okay. Boosting the brakes. And ketamine works differently, you said, via NMDA receptors.
Exactly. Ketamine's main job is blocking NMDA receptors. These receptors are normally activated by glutamate, which is an excitatory neurotransmitter important for things like pain signals and memory.
So ketamine blocks the on signal.
In a way, yes. By blocking glutamate at the NMDA receptor, ketamine disrupts those excitatory pathways,
Yeah.
leading to that dissociative state. Pain signals don't get through effectively. Memory formation is disrupted. That's why its effects are so different from the GABA agents.
Fascinating. Okay. Step 3 then is linking those receptor actions to the clinical effects we actually observe.
Right, so loss of consciousness. That's largely driven by that GABA enhancement, quieting down the networks that keep us awake.
Makes sense.
Analgesia, pain relief. Ketamine does it directly by blocking NMDA. The GABA agents aren't primary pain relievers in the same way, but they do have some indirect suppressive effect on pain processing centrally.
And memory loss, amnesia.
That seems to come from disrupting activity in key memory areas like the hippocampus and cortex. Both GABA and NMDA modulation likely play a role there, preventing memories from sticking.
Okay.
And muscle relaxation, often that's more of a secondary effect of the overall CNS depression from these agents, making motor neurons less excitable, though sometimes specific muscle relaxants are added deliberately.
Got it. And the final step, how do the effects wear off? Termination of action.
Crucial for waking the patient up. For inhaled agents, it's mainly just breathing them out. They diffuse back out of the blood into the lungs and are exhaled. And again, low blood solubility, like placebo, means faster elimination, faster wake-up.
Okay. And IV drugs.
It's different. Propofol, for example, first rapidly redistributes from the brain into other body tissues like muscle and fat. That causes the initial quick wake-up after a single dose.
So it's not gone, just moved somewhere else.
Initially, yes.
Yeah.
Then it's broken down, metabolized mainly by the liver through a process called glucuronidation, and the inactive bits are cleared by the kidneys.
Right. And ketamine.
Ketamine is also metabolized by the liver using that cytochrome P450 system, specifically an enzyme called CYP3A4, which pops up a lot in drug metabolism.
I've heard of that one.
Yeah. Interestingly, one of ketamine's metabolites, called norketamine, is actually still active, has some pain-relieving effects itself. Eventually, these metabolites get filtered out by the kidneys. Knowing how they're cleared is key to predicting how long they'll last.
Which leads us nicely into pharmacokinetics, absorption, distribution, metabolism, excretion, ADME. The document has that handy table for sevoflurane, propofol, and ketamine.
Yeah, that table's a great summary. Sevoflurane, inhaled, rapid onset, mostly breathed out unchanged, very little metabolism.
Okay.
Propofol. 4, even faster onset, heavily metabolized by the liver, kidneys excrete the inactive stuff.
Right.
Ketamine.
Mm-hmm.
4th, onset in maybe 30 to 60 seconds, metabolized by the liver's CYP3A4 enzyme. Kidneys clear the metabolites, including that active norketamine. It just highlights the different paths as these drugs take through the body.
Very useful comparison. Now, Clinical Pearls, the document mentions context-sensitive half-life for propofol. What does that mean in practice?
Yes, this is super important, especially for ICU sedation. The context-sensitive half-life tells you how long it takes for the drug level in the blood to drop by half after you stop a continuous infusion that's been running for a certain time. The context is the infusion duration.
Okay, so it changes.
Exactly. With propofol, the longer the infusion runs, the longer this half-life becomes. After a quick single dose, redistribution makes you wake up fast. But after hours or days of infusion, propofol builds up in fatty tissues.
Like a reservoir.
Kind of. So when you stop the infusion, the drug has to slowly leak back out of those tissues into the blood to get metabolized. The bucket analogy in the notes is good. A splash evaporates fast. A full bucket takes ages to dry.
So waking someone up after a long propofol infusion can take much longer than you'd expect from a single dose.
Much longer. It has real implications for weaning sedation in the ICU.
That's a really key concept. The other pearl was about etomidate and adrenal suppression.
Yes. Even a single IV dose of etomidate can interfere with cortisol production. It blocks an enzyme, 11-hydroxylase, that the adrenal glands need to make cortisol, our main stress hormone.
Just one dose. Wow.
Yeah. Now, etomidate is sometimes liked in emergencies because it's usually pretty stable for blood pressure, hemodynamically stable.
Okay.
But this risk of adrenal suppression is a serious consideration, especially in patients who might already be stressed and need their cortisol, like patients with sepsis or critical illness. In those cases, you might choose a different drug if possible.
Right. Weigh the pros and cons carefully. Okay, let's talk problems, adverse effects. What can go wrong, and how do we fix it? This table format helps here.
Knowing the potential downsides is crucial. Cardiovascular-wise, we mentioned hypotension with propofol, that vasodilation management, fluids, maybe vasopressors to squeeze the blood vessels.
Okay.
Conversely, ketamine can sometimes increase blood pressure and heart rate because it stimulates the sympathetic nervous system. So you might need beta blockers or other antihypertensives if that happens.
Got it. What about breathing?
Respiratory issues are common. Many general anesthetics can depress breathing, causing apnea, or breathing stops, or just making the airway floppy and obstructed. That's why anesthesiologists are always ready to support breathing, manually or with a ventilator, and manage the airway.
Always protecting the airway, neurologic side effects.
Ketamine can sometimes cause delirium or emergence reactions, confusion, hallucinations as the patient wakes up. It's linked to that NMDA block.
Right.
And PONV, postoperative nausea and vomiting, is pretty common, especially after inhaled anesthetics.
Yeah.
probably due to effects on neurotransmitter centers in the brain. We usually manage that with anti-sickness drugs like ondansetron.
Okay. And the really serious one, malignant hyperthermia.
MH. Rare, but potentially lethal.
Hmm.
The genetic thing. Triggered by volatile inhaled anesthetics and also the muscle relaxant succinylcholine in susceptible people.
What happens?
Basically, there's a defect in a calcium channel in muscle cells. The trigger causes massive calcium release, leading to sustained muscle contraction, incredibly high metabolism, skyrocketing temperature hyperthermia.
Sounds terrifying. How is it treated?
Immediately stop the trigger drug. That's step one. Give 100% oxygen, start aggressive cooling. And most importantly, give the antidote, dantrolene, intravenously. It works by blocking that calcium release. Fast recognition and action are absolutely key.
Dantrolene for MH. Got it. And we already covered adrenal suppression with etomidate, so when should these drugs absolutely not be used? Contraindications.
Right, there are absolute ones, definite no-goes.
Right.
A personal or family history of MH is an absolute contraindication for volatile anesthetics and acetylcholine.
Makes sense.
And a true severe allergy to propofol, often related to its egg or soy components in the emulsion, is also absolute.
Okay. And relative contraindications, more like use with extreme caution.
Exactly. Situations where the risk is higher, benefits need to strongly outweigh risks. For instance, using ketamine in someone with uncontrolled high blood pressure or active psychosis could make things worse. And using etomidate in someone with septic shock because of that adrenal suppression risk in an already very sick patient is generally avoided if alternatives exist. It all comes back to knowing your patient's history and current state.
Underscores that pre-op assessment again. What about mixing these drugs with other medications, drug interactions?
Huge consideration. Combining general anesthetics with other CNS depressants, think opioids, benzodiazepines, will have an additive effect. Deeper sedation, more risk of respiratory depression.
Need to adjust doses, usually.
Definitely. Inhaled agents can also make neuromuscular blockers, the muscle relaxants, work more strongly or longer.
Okay.
Ketamine plus other drugs that stimulate the sympathetic system, like some decongestants or stimulants, could theoretically increase the risk of high blood pressure.
Right.
And an important exam tip mentioned, thiopentol can prolong the QT interval on an ECG. If given with other QT prolonging drugs, like the antiarrhythmic amiodarone, there's an increased risk of serious heart rhythm problems. Always check that medication list.
Good tip. Let's get practical with some numbers now, dosages, and a few more pearls.
Okay, specific ranges are helpful guides, so always tailor to the patient. Propofol induction, usually 1.5 to 2.5 milligrams per kilogram IV. For maintenance infusion, somewhere between 50 and 200 micrograms per kilogram.
Micrograms for maintenance, okay.
Ketamine induction, generally 1 to 2 milligrams per kilogram IV. But for pain relief, much lower, maybe around 0.5 milligrams per kilogram IV.
Big difference.
Big difference. Sevoflurane. The MAC minimum alveolar concentration to stop movement in 50% of patients is around 2% in a typical adult. But remember, MAC goes down as people get older, so elderly patients need less.
Lower MAC in the elderly. Got it.
And just to hammer home the pediatric point, sevoflurane is often the go-to for inhalation induction in kids because it's less pungent, smoother start.
Good recap. What if things go really wrong? Toxicity, overdose, or unexpected reaction?
Well, there are specific syndromes. We mentioned propofol infusion syndrome, Priasos rare, linked to long high-dose infusions, causes nasty metabolic acidosis, muscle breakdown, heart problems. Management is stop the propofol immediately and intensive supportive care.
Okay.
And malignant hyperthermia, again, the key is dantrolene. The initial dose is typically 2.5 milligrams per kilogram IV, given rapidly. You might need to repeat doses, plus aggressive cooling and supporting organ systems. Early recognition, aggressive treatment.
Crucial. Finally, the document highlights some black box warnings and high-yield notes, the really critical safety stuff.
Yes, these are non-negotiable safety points. Propofol has a black box warning.
Oh.
Risk of potentially fatal respiratory depression. It must only be given by trained personnel who can manage an airway and provide ventilation.
Essential point.
Etomidate. A black box warning about adrenal suppression, and it's generally contraindicated in sepsis because studies linked it to worse outcomes.
Okay.
Thiopindals.
Yeah.
Warnings about severe hypotension and that absolute contraindication in porphyria.
Right.
And the super high yield fact to lock away. Ketamine is often considered hemodynamically stable or even supportive of blood pressure. This makes it a potentially good choice in unstable patients, like in trauma or shock, where avoiding further drops in blood pressure is paramount.
Ketamine for the unstable patient. Good takeaway. Wow, this has been incredibly thorough. To help consolidate all this, especially for exam prep, there's that final checklist. What are the absolute must-knows from that list?
Okay, quick rundown. Know the core mechanisms. GABA versus NMDA is fundamental.
Yep.
Malignant hyperthermia,
Mhm.
triggers, volatiles, sucks, treatment, dantrolene, memorize that.
MH and dantrolene, check.
Allergy history. Always ask specifically about propofol, Exoi, and maybe thiopental.
Allergies, crucial.
Monitoring.
Yeah.
Vital signs, HR, BP, ET Kioros for ventilation, maybe BIS for depth of anesthesia. Continuous vigilance is key.
Monitoring, nonstop.
And finally, reversal. Remember, for most general anesthetics, there isn't a magic antidote like naloxone for opioids. Management is mainly supportive care. Keep the patient safe while their body clears the drug.
No easy reversal, so prevention and support are key.
Exactly.
This has been fantastic, really packed with essential information for anyone learning about medicine, a true deep dive.
It's a complex area, no doubt, but absolutely foundational for so many medical and surgical practices.
So